What are the anatomical and physiological effects of this technique?
May I go first?
You may.
Yeah,
You absolutely may.
because as a myofascial release therapist, here's where you start dragging things up from the rabbit hole that you were taught from, talking about the little piece of disparate science that are sort of dragged together to create what seems like a cohesive model, but just gets trashed by anybody who really understands the science behind it. And, when I teach this work, we kind of lay out layers of plausibility. We talk about potentially, it might be the fascia. It could be a primary fascial dysfunction, and that we're able to selectively target fascia to the exclusion of all other tissues. But that's really low on the plausibility scale, even though MFR therapists thinks that's it, right? I'm fond of a couple other models. One is a neurodynamic technique model. Basically that every nerve resides within a tunnel, and the fascial people will say, yeah, it's a fascial tunnel. It is, but every nerve resides within a tunnel, whether it's a major trunk nerve, peripheral nerve, or even the cutaneous nerves. And if the nerve gets restricted within that tunnel, you're going to get sensory or motor dysfunction, a problem of some sort. The neurodynamic concept is you take that nerve up to its greatest length, and floss it or glide it within that tunnel to free it up, reducing sensory deficits, improving motor performance, that sort of thing. I'll get to my point in a minute here. I'm going. Neurodynamic technique tends to be more a physio type of a technique for arms and legs. They've mapped out a lot of the major trunk nerves, for instance, the ulnar nerve. When you do this with your arm, that puts the left ulnar nerve up on its greatest tension point, right? And I'm going to do my right one now just because that feels better to me. If I do that, and if I start to get known effects along the distribution of my ulnar nerve, I can have a reasonable assumption that there's a tunnel syndrome within that nerve, right? Diagnostic turns immediately into treatment, and that just, it feeds right into the way I work too, because evaluation immediately rolls into treatment. From a neurodynamic perspective, if I get effect along that nerve, I take a hold of potentially the head, the origin of the nerve, and we do a little bit of gliding and flossing of the nerve to try and free it up, or various points along the distribution of the nerve to see if you can reduce the effects. And what's neat, and where I'm bringing this into the SLP and the voice world, is there's a paper by two researchers by the name of Adderis and von Peekert, who did a study on Parkinsonian dysarthria and the application of neurodynamic technique for dysarthria in the Parkinsonian's patient. And by the author's admission in the paper, it's the first paper that's bridged that gap, that's crossed the bridge between neurodynamic technique in the SLP population. And that's what I really love about that paper, because they're taking hold, and they literally show you in the paper, they're taking hold of terminal distributions of the facial nerve and essentially doing nerve glides right there to improve articulation. And to me, that's the kind of science we really need to support this work. That really, I kind of lost the track of the question there, but the anatomical and physiological effects in terms of neurodynamic, right there.
May I interject with...
You can absolutely, while I look at my notes and listen at the same time. Yeah.
We have receptors, mechanoreceptors in the skin, and they, when put on a stretch, or indeed touched or stimulated with heat or light or electricity, in some cases, will have sent signals from the brain to those receptors and then back, and that as a communication, I suppose in the simplest terms, brings the body's awareness to where you're touching. I think it's the simplest way of putting it. Why that's interesting, I just finished reading a paper on laryngeal myofascial pain syndrome, where they took in the EMG test, they measured this pain, this laryngeal myofascial pain, and the function of speech without seeing any nodules or any kind of pathology or muscle tension dysphonia per se. After doing the EMG, they found that just doing that diagnostic test, that 5 out of the 16 patients had improved speech quality. And so that comes into your diagnosis versus treatment thing, which I think we'll get onto. But it's that idea that we can touch or we can affect with stimulus an area of the body, and the body will react to that.
Yeah. That was work that Diane Jacobs, the Canadian physiotherapist, taught me about Ruffini mechanoreceptors.
Right.
Ruffinis are lateral skin stretch mechanoreceptors. They're slow adapting. So as long as I continue stretching the skin in a lateral direction, which is any direction, Ruffinis continue to signal up to the brain, right? They don't signal a specific outcome. They simply say, brain, pay attention, something's happening here, right? And if the brain essentially has an opportunity to change outcome, and the cool thing about that was when I sat in Diane's class many years ago now, and she talked about Ruffini mechanoreceptors, and she talked about what happens to stimulate them, and it's basically somebody doing this, and I had to like check out of the room for a moment there and try and envision something I do in my myofascial release day that does not involve stimulation of Ruffini mechanoreceptors, right? And I couldn't think of it.
No.
Not that it explains everything.
No.
But you can't, like,
You can't ignore that.
it comes free with the territory, right? You've got this huge piece of the skin that you're grabbing hold of, stimulating the brain for potential change. Instead of saying, no, it's all underneath the skin's a part of it. You can't ignore that. So there's some possible effects with myofascial release, whether it's neurodynamic or skin-based, or, then work your way layer by layer, right? It could be muscle, it could be fascia, it could be a lot of other things.